the nephrology department, there will be always a reference comes for the opinion related to contrast imaging to be done or not, as the risk of AKI might be high, or they want a particular investigation to be done. For example, CCT chest to be done, they want clearance. The topic of discussion is related to that contrast-induced nephropathy or CT contrast related kidney disease. Pertaining to contrast and the kidney, MRI contrast is there, CT contrast is there. Today we are going to discuss regarding the CT contrast. Computerized topography, CT contrast or coronary angiography, they use contrast. Iodine based contrast is the topic of discussion. First, the terminology. Contrast induced nephropathy or contrast induced AKI. Previously it was called as contrast induced AKI. Now, since the mechanism, it is not only contrast, there are some associated factor which is causing the kidney injury. That is why it is called as contrast associated nephropathy or contrast associated AKI. The third one, since it is occurring after the contrast, it is called as post contrast AKI. So the three terminology, all three are correct. Commonly we use contrast associated acute kidney injury. So when to say this? Whenever there is a rise in creatinine within 48 hours. 48 hours or up to 3 days also possible. For MCQ purpose, you can take it as 48 hours. How much rise? 0.5 mg per deciliter or 25% rise from the baseline. This is the definition. Whereas any definition we use for acute kidney injury, that is 0.3 mg per deciliter rise or doubling of the creatinine, or even oliguria criteria also can be used as per the KDIGO recommendation. Any AKI, acute kidney injury definition, you can use it. Pertaining to contrast induced nephropathy, 25% rise or 0.5 mg per deciliter rise in the creatinine. We can say it as contrast induced nephropathy or contrast associated some kind of kidney damage is occurring. Coming to why it occurs. The iodine contrast having some kind of character, osmolarity is high. It causes some kind of medullary hypoxia, vasoconstriction, some direct impact on the kidney tubules, all leads to some picture similar to acute tubular necrosis. Similar to, not same as acute, similar to. Some kind of functional damage it is inducing. Viscosity is there, that is highly viscous, causes some kind of medullary hypoxia. Medullary hypoxia, vasoconstriction, some kind of functional and direct impact of the contrast on the kidneys. That is the reason. So what are the risk factors? Do all the patients develop contrast-induced kidney injury? No, all the patients. Even the references we won't get for all. It is for a particular set of patients. So who are all those who are at high risk? One by one, directly without explanation, if I have to go. Diabetic patient whose BP is low, diabetic is one. Those who are having low BP, volume depleted patient who are on ACE inhibitor ARB, patient who are on metformin, any other nephrotoxic drugs including antibiotic, amphotericin, amikacin, any kind of nephrotoxic antibiotics. A patient who is going to receive high amount of contrast, volume wise, if they are going to receive high amount of contrast. Some subtle risk factor is arterial contrast is somewhat higher risk than the venous contrast. This one. And the most important one out of all this, the most important is the EGFR, that is estimated glomerular filtration rate, which reflects the function of the kidney. Probably the reference might have come for that only. More than 45 ml per minute EGFR, usually the risk is very low. 30 to 45 the risk is there, less than 30 the risk is high. So this is the overall summary of those who are at high risk. Even EGFR less than 60 also we might take mild risk of contrast-induced nephropathy is there if multiple parameters are there. Even though EGFR is 50, the patient might be diabetic, on metformin, on ACE inhibitor, yes, the risk is high. So scenario have to be taken as a whole. For example, in surgery, the patient might be presenting with severe volume depletion. During that time, imaging might be required. That time EGFR might be 50, but patient is hypovolemic. The risk is higher. So yeah, overall bird view assessment of the case might be required to assess the risk factor, of which most important is the estimated glomerular filtration rate and the patient hydration. This is very important. Okay, risk factor, like I told in summary, not going into the detail of each particular parameter, otherwise video became very lengthy. So these are all the risk factor. So coming to the next one, with respect to the contrast type, there are three types of contrast are there. Iodine contrast only, there are two type, ionic and non-ionic. Let us not go into the more technical terminology. Like if we stop at the iodine contrast types, high osmolar, low osmolar and isoosmolar. Three types, high, low and iso. It is nothing but osmolarity of the particular contrast which will be injected into the body. High means it might be in the range of 1000 osmoles, whereas in the body the normal osmolarity is 290 around. This is high. Next one is somewhat confusing. Low osmolar, the name is low, but the osmolarity is approximately 600 milliosmol. High, low. Iso means parallel, around 300 milliosmol, similar to. Out of this, which will be best? Whichever is matching the patient's osmolarity. Low osmolar is best. Whereas in India or most of the countries, availability of this low osmolar is difficult. Most of the centers are using, availability of the isoosmolar, iso, whichever is similar to patients or the person's osmolarity is the best. That isoosmolar. High osmolar is very toxic, low osmolar is in between. This isoosmolar 300 milliosmol availability of this contrast is bit difficult. Most of the centers are using 600 milliosmol, that is approximately low osmolar contrast they are using. So out of these three, high osmolar is having highest risk. Isoosmolar is very better, good or better we can say. Low osmolar currently we are using. So this is related to the contrast. With low osmolar the risk is somewhat less. So almost initial summary discussion is done. Coming to the main part, whether the investigation to be done or what is the treatment. At least in contrast associated nephropathy or contrast associated AKI, the statement is very applicable here. Prevention is better than cure. Better to assess the risk factor before contrast itself, better to make it out. Because once contrast associated AKI comes, or if the patient develops unfortunately, the treatment remains supportive. Nephrotoxic drug have to be removed, more of hydration to be given, and with supportive care usually is recoverable situation if the damage is not severe. And with respect to the management including prevention, the steps that we have assessed in the risk factor: adequate hydration before the procedure, using a very low quantity of the contrast agent which is required, avoiding the nephrotoxic drug before the procedure, and reintroducing once the kidneys are good. These are all the steps which can be taken to prevent it. It is always better prevention than treatment. Before that, the most important one, whether the investigation is required or not. For example, a reference comes for acute pancreatitis, they want contrast CT abdomen. For example, if the patient is having mild to moderate pancreatitis, if EGFR is low, conservative treatment can be continued, because that contrast study is not an absolute indication. So first what you have to review is whether that study is required or not. Many a times from pulmonology department, a patient might already started on ATT based on X-ray and clinical finding. Probably they want to confirm it through CCT. CCT might not be required because already treatment is ongoing. Any condition where without imaging treatment is already ongoing, imaging might not be required. Other modalities, non-contrast CT or any other non-contrast MRI, if it yields a good outcome, probably that you have to select. And one more thing, if the imaging is going to change the treatment outcome, then a contrast CT, the risk and benefit have to be validated, then decision to be taken. Because EGFR, if it is low, the risk, if it is high, better to avoid it. If that investigation is not very much compulsory and treatment line is not going to change. So a nephro resident or medicine resident who is seeing this video, make sure you are assessing why they want to do that particular CT. For example, they might want to do a CT of a brain contrast CT in a 75-year-old male who is case of CVA already on particular infarct, CVA infarct related treatment. That angiography might not be required. You can better wait because treatment is already ongoing. Because angiography we are not going to do any intervention. If we give contrast, kidney is at risk. So better to avoid in that scenario. Let us take scenario number 3 or 4. Already 2, 3 we discussed. Let us take a situation where a patient is having acute MI. Patient is planned for coronary angiography plus minus angioplasty. EGFR is 28. That time contrast you have to proceed with because that is more important than looking at the kidney. Because patient is having acute MI, angiography or angioplasty to be done. So as the scenario changes, clinical scenario changes, the decision of contrast to be given or not will also change. So once develops, management usually conservative. There are many things which are tried like sodium bicarbonate, N-acetylcysteine, phenyldopa, vitamin C, statin. None of them have proven to be any particular benefit, but overall a patient scenario and other patient related parameters, BP control, sugar control, these have to be taken into consideration. And one important clinical point related to contrast associated AKI is many a time after contrast, patient might develop AKI because of some other reason also. If contrast is given, if AKI occur on the third day, always look for some other cause also before labeling it as contrast-induced nephropathy. And a few more points in contrast-associated nephropathy. Biopsy, kidney biopsy is of no value. Biopsy is not indicated because it is not going to show any specific finding. Second, most of the time patient urine output is fine. Patient rarely goes for oliguric kidney failure. It is mostly non-oliguric. The recovery is more rapid. Before 2 weeks only patient will recover or reach the baseline status if conservative care is given adequately. In that conservative care, most important is the volume management and avoiding the nephrotoxic drug. And one MCQ point if I have to tell regarding for the PG students, FENA, fractional excretion of sodium can be less than 1, but that is for MCQ purpose. For clinical purpose, we might not calculate. Some other finding related to contrast induced changes in the body can be there, like itching, some kind of hypersensitivity reaction can be there, which are of theoretical description you might have studied in the book, but not practical. You might not see those. So that's all we have discussed. Good enough, around 5 to 10 minutes we discussed regarding contrast associated AKI. In summary, prevention is better than cure in this condition. Always look why the imaging is being done. If treatment is not going to change after imaging, don't do if the risk is high. EGFR less than 30 is at highest risk, mostly non-oliguric AKI. 0.5 milligram rise over 48 hours, recovery is good. Bye bye, we'll see you in another video.